Thank you, Dr. Mativo. I think we can start since we have a lot to cover. Because I think each cranial nerve you can spend 1 hour just talking about all the.
This lecture, when I look at it, needs at least 2 hours.
Yeah.
No, honestly, if you're 2 hours, the slides you have are for 2 hours.
So we'll start with some basic review of anatomy. We come into this lecture with the premise that everyone knows the neuroanatomy because now we are moving on from there. So we'll just review a few basic concepts, including the cranial nerve rule of force. So Karishma, you can tell us rule of force. Sally? So there's 12 cranial nerves. There is 4 in the medulla, 4 in the bones, and 4 which are suprapontent, of which 2 in the midbrain. And then another rule to help you, so it's to help localize lesions. Another rule is that all the cranial nerves which are, you can multiply them into form 12, except 1 and 2 are in the midline. So you can see the nucleus of 3, 4, 6, and 12 are in the midline, and then the rest are all lateral. So this is part of a general brainstem rule of force where there are 4 midline structures which start with M and 4 lateral structures which start with S, and then you know if you know where the nuclei are located, you can easily classify any brainstem syndrome. So this is a review of the function of the cranial nerve. I think this is very basic. We have covered it several times, including when we are doing examination. So this is also just for reference purposes. There are other slides which I have included in the presentation, but which will not be part of this talk, which when you go back you can easily review the anatomy and the physiology and how to examine the cranial nerves. So when we look at clinical features of cranial nerves, cranial nerve pathologies can either present as mononeuropathies or polyneuropathies, where multiple cranial nerves are affected. When it comes to a mononeuropathy, even the manifestations of that cranial nerve will depend on the location in which the cranial nerve is affected, because as it gives off other branches, the manifestations will actually change. And then there are also upper motor neuron lesions and lower motor neuron lesions, which also present differently, as we'll see in facial nerve and the hypoglossal nerve. And then with polyneuropathies, we know that there is something which is affecting many nerves. So mostly it is due to local causes, which can be intramedullary and extramedullary. But even if it's intramedullary and extramedullary, the manifestations of those neuropathies will be different. Can anyone give me a reason and an example of why, if it's intramedullary, it's going to be a different manifestation with vis-a-vis extramedullary? Maybe upon that. Joe. So we all understand intra and extramedullary, right? So within the parenchyma. So if we assume that there is a lesion outside, like around in the medulla, okay? So apart from the cranial nerves which are going to be affected, the other structures in the medulla which are going to be affected there. So we have other tracts as well, descending, ascending tracts, which will also be affected. So the cranial nerve neuropathies will not be in isolation. Whereas if it's an extramedullary lesion, let's say that there is some foraminal stenosis, or there is a mass there, or there is an infection, then the neuropathies will be isolated to the cranial nerves. That's how you can even localize whether it's within the medulla or outside the medulla. So we'll jump straight into a case, because this will be a case-based presentation and we'll be discussing and learning from the cases. So we can start with Caroline.
So a 6-year-old man presented to the emergency department because of gradual blurring of vision in his right eye over 20 days and progressive loss of vision in the left eye over the previous 8 months. 1 year earlier, he had started taking sodium valproate for morning migraines with only a partial response. Visual acuity was 20/30 in the right eye, and he could perceive only hand motion with the left eye. He also had a left relative afferent pupillary defect and left-sided anosmia. The other results of neurologic examination were normal. So this is a patient who has gradual blurring of vision in the right eye and complete loss of vision in the left eye. So you're thinking there's optic nerve involvement here, and also with the left RPD, then optic nerve involvement, but also has a left-sided anosmia. So you're thinking also of our olfactory, so nerve 1 and 2 involved on the left completely, and probably on the right you also have, so it's a bilateral optic nerve involvement with a left-sided olfactory nerve involvement.
Okay, so if you're evaluating the patient clinically, what's the next thing you want to do for the patient given this?
So you already have your visual acuity, you already have a RPD, and you've seen that the patient has anosmia. So, like investigations that you want to do?
Just clinical examination.
Okay, so you don't to see if there are any other nerves affected. You already know it's
so everything is normal. The only thing you picked up was relative afferent pupil defect and left-sided anosmia. So if you remember the mnemonic for cranial nerve 2 examination, it was
Africope, yeah.
So there's something which we...
So you've done acuity, you want to check for your visual fields. So everything is normal, visual fields is normal.
Yeah, but it's difficult to check because of the acuity problem.
Okay, extraocular eye movements,
they're
normal. Reflexes, you've already said there's a relative RPD. Then, what's the pupillary size? Are they dilated?
No, they're normal.
They're normal, okay.
Everything else is normal.
So fundoscopy?
So this is the fundoscopy. So A being the right eye and B being the left eye. So somebody interpret us the fundoscopy findings. Imran?
So you can see the left eye is actually normal. Is it?
Blurring of.
Oh, it's actually more. It's actually distinct. I think the margins are distinct.
Okay.
The right eye, on the other hand, is swelling of the optic disc. There's some swelling in the optic disc, and there's also some red discoloration within the central part of the optic disc. So reddening. So there could be some edema, and the disc margin is also not very clear.
So there's papilloedema in the right eye, and what about the left eye?
Atrophy, probably.
Optic atrophy.
Atrophy.
So now put everything together. Papilloedema of the right eye, optic atrophy of the left, and anosmia.
So this increased intracranial pressure. So probably the left one, because of probably long-standing papilloedema, got atrophied, maybe.
When they say increase in the cranial pressure, the other cranial nerves are normal. What do you usually see with increase in the cranial pressure?
So why is the atrophy in the left and papilloedema on the right? And anosmia on the left? There's a syndrome I'm alluding to.
Very rare syndrome, but anyway.
So this is Foster-Kennedy syndrome. Okay, there is a. I think it was mentioned yesterday by Dr. Soto.
I never mentioned
No,
it.
Okay, you didn't mention
yes.
but you mentioned that olfactory group meningioma. So this is caused by an olfactory group meningioma. So if the meningioma is on the left, it's going to compress the optic nerve on the left, so it's going to cause optic atrophy because of pressure. But because of the presence of a mass in the brain, it's going to lead to increased ICP, which is going to lead to papilloedema, and there's going to be left-sided anosmia as well. So this together constitutes a Foster-Kennedy.
So is this a subfrontal meningioma?
Yes.
Why is it only one side? Wouldn't it compress both olfactory?
No, it's on the left.
It's unilateral.
Oh, it's
unilateral.
Okay.
It's in the olfactory group.
Is a frontal lobe tumor, regardless. Meningioma is one of them.
Okay. So, with olfactory neuropathy, you can get anything from anosmia, hyposmia, dysosmia, or you can also get phantosmias, which is spontaneous olfactory hallucinations. And just wanted to display this so you can see that the olfactory nerve fibers go through the cribriform plate and then join the olfactory bulb, and then the nerve travels to the temporal lobe, and that's why even when you get temporal lobe epilepsy, you can get olfactory hallucinations. And the reasons for olfactory neuropathy, in fact, the most common cause of anosmia is actually local causes in the nose, if there is mucosal edema because of infections, rhinitis, or smoking. But you can see this cribriform plate, if in case of coup or counter-coup injuries, this can easily get sheared. So another common cause is, when you get a patient with anosmia, is to ask about history of trauma. We've mentioned, we've illustrated Foster Kennedy syndrome, that is a frontal lobe mass, which you can see is going to compress on the olfactory bulb. And then, as we know, with neurodegenerative disorders like Parkinson's, even Alzheimer's, one of the first earlier signs is anosmia. Multiple sclerosis can also cause this, and congenital, if it's a young male or female, delayed puberty in the case of male, then you can think about things like Coleman syndrome.
Coleman syndrome.
Hypopituitarism.
Yeah.
Hypogonadotrophy.
So we can move on to case scenario 2. Maybe Karishma, you can take us through it.
A 54-year-old woman presented to the ophthalmology emergency department with a 10-day history of blurred vision. She was known to have relapsing remitting MS and had previously suffered from retrobulbar optic neuritis. The best corrected visual acuities and Ishihara color vision were bilaterally reduced with the left RAPD. Slit lamp examination was otherwise normal. What is the next step in her evaluation? So, she's known to have MS and she's had optic neuritis in the past. So, you've done visual acuities, you've done color vision, and pupillary exam has an RAPD on the left. So, fundoscopy?
You've done slit lamp, it was normal.
Okay. Fine. The rest of the cranial nerve exam?
No.
It's all normal.
Clinically, is there any other thing you'd send her for or do? Probably send her for.
You've done the entire neurology exam and it's fine.
BP. Usually for the box potentials.
Okay, you can do that.
It's a test.
MRI scan.
So what clinical examination?
Yeah, so if anyone has blood vision, okay, what else would you want to do? You do visual fields by confrontation, but you don't do formal visual field examination. Yeah, so she actually had visual fields which demonstrated an incongruous left homonymous hemianopia. So what does that mean?
Do you know if it's
homonymous
versus congruous?
So the left side here, you can see you don't have a visual field on the left.
Okay.
But it's incongruous, which means the right and the left aspects of the visual field are not symmetrical, and that's what's called incongruous. As opposed to congruous, where both of them will be equally symmetrical or loss of vision. That is congruous. That is incongruous.
Okay, congruous is the same, incongruous, different visual field. So
What's the significance of congruity?
Location.
Location.
Yeah.
So the more congruous, the more posterior it is. And it's left homonymous hemianopia. So where do you think the lesion is located?
On the right.
Okay, what way?
Right, it's occipital. It depends.
it's
So-
incongruous.
So it's incongruous.
So if
The more posterior you go, the more congruous it gets.
So it's like close to the chiasm, just
So it's
distal to the optic
retrochiasmal,
chiasm. Yeah.
probably proximally.
Yeah.
Okay. So now that you know that she's got incongruous left homonymous hemianopia, what are your differentials? Stroke is possible. What else?
she has MS, so she could be having a demyelinated lesion.
Okay, edema. You mean a flare?
Yeah.
Okay. So those are two good differentials. So it could be stroke, it could be an MS flare, and that's why we would want to do an MRI, and an MRI was done which actually showed a flare of MS in the right thalamus region. Okay, so it's always important to do these visual fields to localize the lesion, because initially the way this patient was managed was they thought, oh, it's just a flare of MS, is just retrobulbar optic neuritis, but when they did the visual fields, they got concerned about a stroke and had to do an MRI. So we'll talk a bit about optic neuropathy, where there is unilateral or bilateral visual loss. If there is pain, it is usually specific for optic neuritis, which you get with things like multiple sclerosis. And color vision loss is actually very important. There is also afferent pupillary defects. I think we have described the loop of the afferent defects, so I won't go back into that. And you'll have visual field defects. We'll have a whole chart about visual field defects. And optic neuropathy can be anything from traumatic. We saw in Foster Kennedy syndrome there's actually those compressive optic neuropathy. We can get ischemic optic neuropathy, and then you can get optic neuritis. One of the most important causes of this is demyelination, like multiple sclerosis, neuromyelitis optica. You can also get toxic because of medications, like our patients on anti-TBs can get optic neuritis because of ethambutol, also alcohol use. In our setting, also metabolic causes will come in, especially nutritional deficiency. Even vitamin B12 deficiency can cause. Ischemic is important because of diabetes, and if a patient gets that, you can think that it could be an ischemic cause. And infectious mononucleosis is among the infectious causes. So we'll go to the visual fields. So I think these are self-explanatory. So you can see the left eye, the right eye, then there is the temporal and the nasal fields, the temporal of the left eye and the nasal, and then the nasal fields actually project to the temporal part of the retina and vice versa. So the temporal fields will come in the midline and then they will decussate. So depending on the location of the lesion, so if you get a lesion here, the optic nerve will be, you'll get loss of vision in one eye. But if it is a chiasmatal lesion, then you'll get bitemporal hemianopia. And then if the lesion is on this side, then you'll get contralateral homonymous hemianopia. And then you have the temporal and the parietal. And you always remember, I remember lumbar puncture LP. So the lower is parietal and temporal is upper quadrantanopia. And then you come to the occipital lobe, where you'll also get homonymous hemianopia, and then the one in the occipital lobe will be because of macular sparing. And why is that?
Because of the bilateral blood supply, the occipital lobes.
So it's actually because the macula is supplied by the MCA. Okay, so that's why if you have PCA infarction, then there will be macular sparing. But sometimes when the MCA is infarcted, you can get this right homonymous scotomas. Okay. So if you want to localize any lesion with the visual fields, then you just ask yourself 4 questions. So the first question is, if there is a does the visual field defect involve one eye or 2 eyes? So if it's one eye, then it's most likely the optic nerve. Okay. If it's 2 eyes, then it could be both eyes, because you might be unlucky and get defects in both eyes, but it might be a chiasmatal or retrochiasmatal lesion. Then the next question you ask yourself, if it's 2 eyes, does the defect respect the vertical meridian? In the case, like you can see that one is respecting the vertical meridian, but if it's a horizontal lesion, then it's not going to be anything retrochiasmatal. Okay, then in
what does it infer if it's vertical?
So it infers that it's
as it horizontal.
horizontal. It infers that it's in front.
So it's an optic.
It's an optic neuropathy.
So it's called an altitudinal defect, meaning it's one versus the other. So people say I can not see the top, I can see the bottom of the person, and usually that's like an ischemic optic neuropathy.
So in which case, then you'll be unlucky enough to have bilateral optic nerve problem. But if it respects the vertical meridian, like in this case, then you know it's chiasmatal or retrochiasmatal. And then the next question you ask yourself is, this is straightforward, I think we've covered it many times. If it respects the meridian, is it homonymous or bitemporal? If it's bitemporal, then we know it's chiasmatal. If it's homonymous, then we know it's contralateral. And then if it's homonymous, is it complete or incomplete? So if it's complete, it will not give you any further information. But if it's incomplete, then you see if it's congruous or incongruous. The more congruous it is, the more posterior it is. So that can be an MCQ question, and you can get several choices. So we can move on quickly to case scenario number 3. Maybe Joe, you can take us through it.
73-year-old smoker who had controlled hypertension and diabetes had a 5-week history of leukocytosis and diplopia. The patient had normal visual acuity, color vision, and visual fields in each eye. Pupils were isophoric and equally and normally reactive to light and near stimulation. The right upper eyelid was in normal position and the right eye moved fully in all directions. The left upper eyelid was completely ptotic. The left eye had no elevation, depression, or adduction, but there was normal abduction and intorsion on attempted downward gaze in abduction.
So, what do you think?
Okay, so I'm just looking at in terms of the extraocular muscle defects in the left eye. So it looks like the sparing of the cranial nerve 4, cranial nerve 4 and 6, with involvement of nerve 3. And aside from that, the pupils are not affected. So I think it's like what we call a medical.
Yeah, excellent. So it's a third cranial nerve palsy.
Why is the pupils not in the medical?
Okay, I think what Asuki was explaining yesterday in terms of the location of the sympathetic parasympathetic component of the cranial nerve 3. It's more external. While in the medical, we talk about more central location of the lesion.
But what is the medical? What is the cause?
So surgical, you think of, I know just what you're talking about. Medical is
Surgical
like
compression.
Compression.
Medical. Okay, affecting what? Yeah, diabetes, but affecting.
It's a vasculopathy.
Yeah, vascular.
So, Joe, now that we are in a part 2 class, how would you evaluate this patient? He's come with you, he's come to you, he's got a medical palsy. What are you going to do?
So I think we are trying to evaluate the causes of why he's getting this kind of 3 palsy. And his evaluation will first of all be anatomy. If I can get any anatomical explanation, so it will be probably not a good imaging for him, probably an MRI scan to be able to visualize the cranial nerve 3 and see if there's any obvious lesion that you're able to pick. But then you can also do other laboratory tests that may predispose him to some of the some of this. You want to check his control of his diabetes, you want to check his HbA1c, you want to check his cholesterol levels, you want to check so this lipid profile.
So the question here is, would you image him or not? Because it's a medical palsy and we know it's because of infarction of the nerve. Will imaging add any value? Because I mean, if you had a pupils are dilated, then you think, okay, there's something going on. So typically, usually you don't image them, you give them some time and see if the lesion resolves. But in this case, the lesion didn't resolve after 8 weeks of observation. So we did an MRI, which is normal. So what do you do next?
Vasculitis screen had been done already.
Here's no features of vasculitis. You mentioned it actually. The first thing.
I didn't mention the evaluation, but I mentioned.
No, you mentioned the cause. An aneurysm. So if MRI is normal, you can do angiography to see if there's aneurysmal. Because although there is this distinction between medical and surgical pupil, but it's not always true, because sometimes there are surgical causes and which don't come with the third nerve palsy. So if you need to give it time. If it doesn't resolve, then you need to look for a surgical cause for this palsy, because usually the medical palsy, most of it resolves within a few months. So I think we are all well versed with the direct and consensual reflex, and because of time I'll not go into, because we have I think 7 or 8 more cases to go, and this is the findings you're going to get with a complete third nerve palsy, including pupillary involvement. And this is a graphic to demonstrate the difference between surgical and medical pupil, and what findings we'll find. And the most common artery which is implicated is the posterior communicating artery. So I think we have covered the pathological features. The etiology, with third nerve palsy, we always, if a patient has ICP, we always checking the pupil, because it's a sign of uncal herniation, because it gets compressed. And the subarachnoid hemorrhage is also one of the causes, because it moves through the subarachnoid space. Meningitis, I think it's one of the most commonly affected nerves. It passes through the cavernous sinus or cavernous sinus thrombosis. PC aneurysms, SOLs, brainstem lesions. I mean, the list is long. I think we can move on to the next scenario. You can read through the causes during your own time. So, Saraya.
A 57-year-old male presented with a complaint of diplopia following head trauma the week prior. He was standing on a stool to change a light bulb in the kitchen when he lost his balance, fell to the tiled kitchen floor, and struck his head. He lost consciousness for less than 1 minute. He noticed diplopia immediately upon awakening, but had no other neurological symptoms. He described painless binocular vertical diplopia that worsened when he looked to the left, but improved when he tilted his head to the left. He thought that the diplopia was worse when he tried to read. He had been closing one eye to help relieve his symptoms.
Okay. So which nerve do you think is affected? Which eye is affected first?
So
from the description.
So the left eye.
Wait.
Tilting his head to wait.
The diplopia is worse in the eye that's furthest away from the...
So if you twist his head to the left, it gets better. So it's the right eye which is affected. And what do you expect to find with extraocular muscle motility?
So, I think adduction, no. His right eye will be abducted. So adduction is the issue. No, abduction is the issue. His right eye will be abducted.
Okay. Usually they have trouble going down the stairs. So they have to look down and in when they're going down the stairs.
Do you have to converge to look down and...
Okay, maybe we can move on to the... So would you image the patient?
Yes.
Yes. You would? Dr. Soki, would you?
Well, he's 57. Is he on any anti-platelets or...?
No.
No.
He's healthy.
I don't know. He's a bit older, so I probably would.
Okay.
Just to make sure he got a subdural, because you can get subdurals in these older people. But I see your point you're making, which is that he's clearly got a mononeuropathy that you want to explain. So
the trochlear nerve is the longest nerve. I think it's 3 times longer than the next longest nerve, which is cranial nerve 6, and it is the most common cause is actually trauma. And from what my reading is, they said if it is an isolated and there's a clear cause of trauma and it's not severe head trauma, then usually there's no need for imaging. But of course,
you see, trauma imaging is important.
It's important.
There was trauma, you don't know how much injury has occurred. imaging how will advance.
Okay.
But the history is electronic.
So the pathological features, there'll be vertical diplopia. That's why even yesterday when we did cranial nerves, we asked them whether which image, and then you cannot move the eye downward and laterally, and then the patient tilt towards the unaffected side. So somebody can take us through this extraocular muscle motility chart. What is A? A is how? In the primary gaze positions, what do you see?
It's the left or the tube.
So you can see that the right eye is a bit higher than the left eye. Okay, and then it gets worse when he is looking towards the left. And this is exactly what our patient said. When he looks to the left, so you can see it goes even higher. But then when he looks to the right, it's normal. So it resolves. And then when he tilts his head to the right side, to the affected side, then things get worse. But if he tilts his head to the left, then things get better. That's why you would find the patients coming to you like this.
Let's say the head tilt is away from the lesion, and the reason is because apart from it going down and in, superior oblique also makes the eye input. Yeah, so if it's not working, then it gets some extortion. Yeah, so for you to now correct that extortion, you tilt your head, so it now comes back into line again. So you get a head tilt away from the lesion. That's called the Bilchowski's head tilt test for trochlear nerve palsy.
Okay, moving on swiftly. Sally?
A 55-year-old white man presented complaining of double vision for 2 weeks. He reported the double vision began gradually and had not gotten worse in the last week and a half. The diplopia was mostly at a distance, but occasionally noted at near. Separation of objects was only horizontal. The patient was able to close one eye to relieve the diplopia, but nothing else seemed to help. He denied tingling or numbness, headache, nausea, scalp tenderness, fever, malaise, or other neurological signs or symptoms.
So this is the primary case. Which eye is affected?
Left.
Okay, so what do you see?
So it's adapted from primary position.
Yeah, so it's adapted because of unopposed medial rectus. So that's when he looks to the right, everything is fine. When he looks to the left,
So there's clear impairment of abduction in the left side.
okay. So this is a complete absence nerve palsy. So how do you manage this patient?
Is the commonest cause? Commonest causes.
What's localizing sign from this diabetes? It's diabetes most common.
So it's called it's also similar to the medical third nerve palsy. Okay, ischemic sixth nerve palsy, which is common in patients who are more than 40 years of age. But you always need to have a caveat. We'll come into it. So we've already covered this. So etiology, it's in the cerebellopontine angle now. It leads through the CP angle. So if there's any tumor there, it can compress. It goes through the cavernous sinus. So if it's in isolation, then it's unlikely. But if it's with other nerves, and then it's a false localizing sign because of the way where it passes through, it can easily get compressed. But one thing you need to remember is vascular DM, hypertension. I remember, Sarai, do you remember Dr. Njenga had
Yes.
in clinic, there was a patient with isolated sixth nerve palsy when he had no other features and imaging was normal.
What was the eventual diagnosis?
The guy who had the fasciculations.
That's
Very those were fasciculations.
Dr. Njenga's patient who had isolated sixth nerve palsy.
It was a microvascular.
Microvascular.
Yeah.
Okay.
So he got better slowly over time.
So we'll talk about microvascular sixth nerve palsy. So in patients above 40 years with vascular risk factors as he was, diabetic, hypertensive, there is microvascular occlusion of the arteriole, and usually sudden in onset and there is complete palsy at onset. But most of them recover, like within 3 months 80% recover, and by 1 year 90% recover. So these patients, they don't need imaging, but you need to rule out like temporal arthritis. So even in our history, we were trying to see if there could be any temporal arthritis, and you can at least do an ESR. But then there's some red flags you need to consider.
Why temporal arthritis?
I'm not quite sure why temporal arthritis. I haven't tried to.
So temporal arthritis is a very strange phenomenon. I mean, yes, perhaps we get the headaches, etc. But the nerves that localize to posterior circulation, they can be involved. You can get microvascular sixth nerve palsies with these people. It's very rare. There have been descriptions of brachial plexus neuropathy being due to chancel arthritis as well, because it's so proximal. But yeah, it's much lower down in the differential. You would normally check an ESR and the CRP, because these people normally, if they do complain of a headache and they're going to be above the age of 50, you want to check an ESR and you exclude that cause.
Because everywhere they say you have to exclude temporal arthritis.
It's interesting. Okay.
So red flags include a younger patient, and then older patients with an atypical signs like subacute or stuttering onset, partial palsy, and other neurological symptoms. So if you get a 7 nerve palsy, what do you think? Yes, well.
CP, yeah.
Yeah, so think of something like CP angle or an infarct. Okay, and failure of recovery in 3 months, then you would consider imaging. So moving on, scenario 6.
65-year-old female presented to her dentist with numbness of the left lower lip, the jaw, and the chin for 1 month. This was similar
to experience.
To her experience of local dental anesthesia in the past. She had no other symptoms, and past medical history was only remarkable for left breast cancer, which was remission for the past 20 years. Head, neck, and dental examination was unremarkable, except for reduced sensation to light touch, vibration, and temperature in the area illustrated alongside.
These are common presentation you will see. So most patients, by the time they have seen a dentist, 1 or 2 teeth are out. Okay, just go.
So what is the structure compromised?
V3. V3 branch of the trigeminal.
Which branch? V3 is
Mandibular.
you know?
Oh, mandibular.
Yeah. So yeah.
Also, there's a mandibular. We're talking about the specific branch of the V3.
Yes.
I think it's an alveolar.
So okay, so it's the inferior alveolar nerve which now becomes the mental nerve.
Mental.
Yeah. So this is the mental nerve. What's the likely etiology of her presentation?
Well, she's been to the dentist. She's had anesthesia before. It's left lower lip, jaw, and chin. And she also has breast cancer. I mean, it could be trauma to the area.
There's no history of trauma.
She's been to the dentist.
No.
Yes.
She presented to the dentist saying that it feels numb here and it feels exactly like how it feels when I'm given anesthesia here. So you know the dentist now they infiltrate the mental nerve to cause a block. So it feels exactly like a mental nerve block. So we have ascertained it's a mental nerve problem. But what's causing it?
Is she on any medication?
Compression.
So it could be compression of it.
From where?
Is that foramen is from?
This one side.
So her past medical history is significant for breast cancer. So actually this is a very specific,
I think it's also necrosis.
no, it's actually metastatic breast cancer.
Really? To the jaw?
Yeah, it's a very common site, and it's like a common presentation of metastatic disease. Some people actually present, the first sign is numbness of the jaw. So don't dismiss people when they say that the jaw is numb. You need to really evaluate them. So she had a scan which confirmed metastatic breast cancer.
This is called numb chin syndrome.
Yeah.
And it's a red flag as well, which is why we brought it up, because especially in this context, you have to just say that there might be metastasis to the mental foramen, which is in the jaw. I've seen 2 cases where
You've seen cases?
Yeah. And in fact, the person who I sent that paper to you, he's my colleague who trained with me.
Right.
And they found that cancer. Yeah.
So we'll just discuss trigeminal neuropathy broadly, and then we'll also go to the Namchin syndrome. So, I mean, the symptoms are, the trigeminal nerve is motor and sensory component, so you can have sensory loss, you can have motor loss as well. And the causes can be anywhere from the origin of the nerve, the pons medulla, and then you remember that the trigeminal nerve nucleus goes all the way to C2, the sensation part. That's why it's involved in lateral medullary syndrome. So anything which is affecting the lateral part of the brainstem from the area of the pons up to C2 can cause involvement of the trigeminal nerve. And then the middle fossa at the Meckel's scale, if you have any pathology, any tumors, any infections, meningitis. Also at the trigeminal ganglion, which is in the petrous temporal bone. V1 and V2 pass through the cavernous sinus, so cavernous sinus pathology will affect those. And trigeminal neuralgia, which is actually caused by compression of the trigeminal nerve as it enters the pons and causes compression there. So what happens is the external fibers of the trigeminal nerve carry like sensation to the face, but not pain in the deeper fibers. So what happens when there is pressure, there is demyelination, and then there is abnormal connections. So when you just have a light touch, it will cause excruciating pain. But again, in somebody who is young, female, the trigeminal nerve is actually myelinated with oligodendrocytes and not Schwann cells for a longer portion than the other nerve. So one of the presentations of MS could also be trigeminal neuralgia. So you always need to keep it in mind when you're evaluating a young female with trigeminal neuralgia. So we have talked about the Namchin syndrome, and it's also called the Rogers sign, where you have this Namchin and it's a presentation of cancer. And common cancers which present this way is breast cancer and also leukemias and lymphoma. So if you get an elderly patient, especially or somebody with a history of cancer, then you should always be suspicious. This is the innervation. So you can see that the mandibular nerve comes and then gives out 3 branches. The third branch is the inferior alveolar nerve. There is the auriculotemporal, the lingual nerve, which can cause numbness of the tongue. And then the inferior alveolar nerve will go through the mental foramen. It emerges from the mental foramen as the mental nerve.
Just to summarize, the trigeminal nerve is also known as the cancer superhighway of the face. Things that are in the face can metastasize backwards very easily. So people can have BCCs, other things of the face, and they can easily spread backwards. Just to keep that in mind.
So, Jamila.
Asian female school teacher presented with a long history of left-sided facial weakness. Examination was unremarkable, but for incomplete left lower motor neuron type of facial palsy.
So what do you think? She's young.
Bell's palsy.
Okay. So how do you manage this patient? She's got Bell's palsy.
She's got Bell's palsy, but you need to exclude, just to do basic workup first, to make sure she doesn't have something that might have precipitated the Bell's palsy. So I'd first do CBC. Of course, take a history, a family history. Do they have diabetes, hypertension, anything that could give a red flag? Then do a CBC and relevant investigations according to the history you've received. And then if it's on 1-day history, studies show she could benefit from steroids.
Okay.
Yes.
Could you give antivirals?
If we have indication for antiviral, does she have a history or something pointing to this could be Happy's school teacher. Are they children, by the way?
So it's what it is, you probably give. So it's not like it's not unequivocal. The opinions will be
there is some slight benefit of adding antivirals to the steroids. So now,
empirically, just give.
Do you give antivirals, Dr. Soki, in your practice?
So the evidence is based on the severity of the Bell's palsy and also if there's any lesions in the ear. So you must always do, in this case, the Bell's palsy, you must always do otoscopy to look for the lesions. And there's this other sign called Hutchinson's sign, which you can get a red spot on the nose that suggests the same thing. That's one. The second one is if they've got severe facial nerve palsy. Severity is graded as per the Brackman score. And if it's a Brackman score of between 4 and 5, which is the most severe, then empirical treatment with antivirals seems to help. But not everyone with Bell's palsy, I put them on antivirals. And it is on a case-by-case basis. So for example, I had a lady who was pregnant on the weekend, and she came in 3 days late with Brackman 4 palsy, but given she's pregnant, I didn't give any antivirals. Yeah, as you get steroids and she got better. So it depends on the severity and if there's presence of vesicles. Yeah.
So now she comes back and she's got bilateral facial nerve palsy, low motor. So that's the change of differential. Do you still think it's Bell's palsy?
And she's received the steroids and antivirals?
No, she didn't receive anything. She was just discharged. She was just reassured it was, I think, house in Brackman 3. So she was just went home, came back 2 days later, saying now both sides are affected. Do you still think it's Bell's palsy? Could it be something else?
So bilateral is common with, so GBS can present in that way. Sarcoid and Lyme can present.
Okay.
Trauma can present with a bilateral.
There was no trauma.
She's not
So would you like some further history?
Yeah, she traveled.
So she now says that 2 weeks earlier she had a sore throat when she got amoxicillin, but she's not traveled, no trauma, no rashes. So they got the diagnosis, very smart class. Okay, so she had GBS. An atypical presentation of GBS which can start with facial nerve palsy and cause paresthesia, and so she was treated with IVIG and she got better. So we can discuss briefly about the facial nerve. I'll just leave it for your reading because we don't have much time. We have maybe 15 more minutes because we started 5 minutes late. So I'll just talk about the facial neuropathy. We all know how to differentiate between upper and lower motor at this stage. And the reason is because of the crossed supply to the upper facial muscles from the cortex. And I'll just talk a bit about the Ramsay-Hunt and Bell's palsy syndrome. So Ramsay-Hunt is one of the differential diagnoses of Bell's palsy, and it's actually caused by herpes zoster infection in the geniculate ganglion of the facial nerve. Okay, so how it's different from Bell's palsy is the things which will make you think of Ramsay-Hunt is if the pain is severe, and if the facial palsy is very profound as well, like grade 5, because that's usually what, and then if there is a vesicular rash in the ear, or sometimes you can get it on the tongue as well, the region of supply of the facial nerve. So with Bell's palsy, the core features, because it's one of the most common causes, we'll talk about it, is unilateral low motor facial weakness. So if you get bilateral, it's highly unlikely to be Bell's palsy. Okay, it's acute but not sudden, so it's not going to come like suddenly. If it's suddenly, then you think of other things like a stroke in the pons, which will also cause low motor neuron, and then the recovery usually begins within 14 weeks. Associated features, most patients complain of a bit of pain because it's thought to be inflammation of the nerve from herpes simplex infection, and then depending on the level, if it is just at the stylomastoid foramen, so all you have is the motor features. But if it's a bit, if it's in the more proximally in the facial canal, then you can get the coda tympani affected. So you'll have altered taste, and you can have hyperacusis because of the nerve to the stapedius being affected. And then because of the parasympathetic innervation to the salivary glands and eye, then you can get a dry eye and mouth. But then there are always red flags, which if you see them, then you think this is not Bell's palsy. Okay, if there is any hearing abnormalities, then you would think that this is not Bell's palsy, it's something else, because then it's around the internal auditory meatus where the eighth nerve also exits the brainstem. If there's severe pain, then you think of Ramsey-Hunt syndrome. But although the management is similar, but in this case you will give antivirals because of the zoster. And if the patient is systemically unwell, then you know there's something else going on. There's a prior history of cancer, then you need to consider metastasis to the base of the brain or carcinomatosis. If there is prior tick bite or Lyme disease exposure, because Lyme disease often presents with facial neuropathies, often bilateral, and then you need to look out for a rash. Okay.
Adil, why would you get a low motor in a pontine stroke? Because the nucleus is the facial nerve. Why would it be?
So upper motor is supranuclear. So the corticobulbar tract or the cortex.
Okay. Any lesion from the nucleus of the nerve will give you lower motor. Anything above the nucleus, upper motor.
What if the person has recurrent Bell's palsy and facial or mouth swelling through their life? What's that called?
There's a syndrome.
It is a syndrome.
It's got a very difficult name.
Yeah, it's called Merkerson-Rosenthal syndrome.
Yes.
Yeah, that's recurrent Bell's palsy, and again facial swelling, lip swelling as well.
Okay. Imran, you got the easiest one.
So just to say that it's not, doesn't have to be herpes simplex virus that causes the irritation of the nerve. So because it goes through such a narrow canal, anything that inflames it will make it choke. That's where you get the pain, and that's a very important point that they do describe the pain behind the head at the time, especially behind the ear. And if they don't post-mortem studies on these people sometimes, and they find mycoplasma sometimes in them and other atypical infections, but it's not always
happens.
Yeah.
Okay.
Okay. 25-year-old female presents to A&E with dysphagia, dizziness, vomiting, and pulling to the left while jogging after a visit to the chiropractor. A neurological exam revealed an ataxic gait with falling to the left-sided ptosis and meiosis, nystagmus with rapid horizontal phase towards the right, decreased left palatal movement, and uvular deviation to the right. The left is abnormal. Decreased pinprick sensation and loss of temperature discrimination over the left maxilla and throughout the right upper and lower limbs.
Easily.
Yeah, so probably in the brainstem.
Where?
So probably lateral medulla.
Okay. So which cranial nerve involved?
So cranial nerves involved in the medulla. These are age 9, 9, 10, 11 and 12. But you also get effect of the sympathetic chain being involved. That's why they get the ptosis and.
But remember, rule of 12. 12 is in the.
So medial. Sorry. So the medial ones are So 12 is medial, whereas the others that's 9, 10, and 11. Those are all lateral. Those would be affected as opposed to medial medullary. And then since it's lateral, sympathetic chain is also lateral, so that's also.
So the four things you start with S laterally. So there is the spinocerebellar, there is spinothalamic, there is the sympathetic chain, and then there is the sensory of the fifth nerve. So remember those four things, and then the nerves affected 8, 9, 10. Okay. So what's the most likely etiology? She's young, she's 25.
So we would look for, so she's young, so we would look for low vasculitic screen for female.
So she went to the chiropractor.
Oh, yeah.
Chiropractor.
So she went to the chiropractor. Remember Placid? What happened? So she had a dissection of the vertebral artery and she got a pica stroke. So these are the structures involved, and this is what you're going to get. It's lateral contralateral. Okay. So I think I'll just skip this slide. You can read it at your own time so that we can finish the cases which are of more benefit.
If I just ask another one, so if this lady had actually gone to a hairdresser and then comes with a unilateral Horner syndrome afterwards, what's the diagnosis?
Is it ischemia because of?
So what is stretching and where? Also known as the heavy metal headbangers syndrome. Not in my headbang, you know, Metallica, Black Sabbath, and all those people. Carotid dissection. Okay, so carotid dissection is documented in women who go to hairdressers because the sympathetic nerve goes up the carotid, wraps around the carotid, and that can get stretched. You get a Horner syndrome from that, and we get the same thing from Moshes. Yeah. Okay.
I think we have just 2 more scenarios. We can quickly go through this one. Back to Carol.
A 32-year-old man who complained of left ear pain, hoarse voice, and swallowing difficulty for 5 days presented at the emergency room. He showed vesicular skin lesions on the left auricle. On neurological exam, his uvula was deviated to the right side, so the lesion is on the left, and weakness was detected in his left shoulder, so spinal accessory nerve on the left. Left vocal cord palsy was noted on laryngoscopy. So here we have involvement of the glossopharyngeal, the spinal accessory nerve,
vagus.
and the vagus. Where could the lesion be located? Is it the brainstem?
Vesicular skin lesions in the left.
He's got some vesicular skin lesions in the left ear. 9, 10, 11. Where do they exit? Jugular foramen. So it's probably something around the base of the brain, the jugular foramen. It's called Burnett syndrome. How do you investigate him? So he had imaging, and you can see that the left jugular foramen is a bit narrow compared to the right, and he had a herpetic infection. His vis-a-vis markers were elevated, the IgM. So he was treated for vis-a-vis and he actually recovered. Okay. So Burnett syndrome is also another name for jugular foramen syndrome, caused by trauma infections, especially like vis-a-vis, meningitis, any granulomatous disease, vascular causes like aneurysms which can compress that area, and also tumors. Okay. So again, I'll skip this. We can read it at our own time. It's just repetition of what we know. Cranial nerve 11. So you can see that there is the pathological features. There is downward and lateral rotation, and you can see how all these nerves exit the 9, 10, and 11 and go through the jugular foramen. And you can see that the shoulder is drooping on the right, and you can see that there is a rotation of the scapula. It's actually winging on the right from posteriorly. So this is how you assess for this. So hypoglossal nerve, again you need to differentiate between the upper motor and lower motor neuron lesions. Upper motor, it's actually corticobulbar, so it's crossed. Okay, so then the tongue would deviate opposite to the side of the lesion with upper motor. Make sense? And with lower motor, it would deviate to the side of the lesion because it gets pushed away from the stronger side. But in the other case, because it's crossed, the lesion would be on the opposite side. And then with lower motor, you get fasciculations and wasting of the tongue. So again, if you look at upper motor, then it's usually vascular causes like strokes or motor neuron disease or tumors. And lower motor, if it's unilateral, then you think of vertebral artery thrombosis, syringobulbar, but most of the time, because you remember 12 is in the midline, so both nuclei are very close to each other. So if one gets affected, usually both get affected, and most of the time it's both nuclei involved. And if it's bilateral, then you get the dysarthria. And if it's upper motor and bilateral, then you would get a very spastic tongue. It will not even be moving. Okay. The last one. Karishma, the lucky one.
So, in A, he's unable to close the left eye.
Actually,
Or the right eye is closed. Okay, so complete
ptosis.
ptosis of the right eye.
What about B?
There's a dilated pupil.
You
on
can
the
see
right
it's
side.
brighter, so
Yeah.
somebody is shining a torch and he's actually elevated the eyelid.
Yeah.
So what do you think? And the position of the eye in B?
Abducted.
Yeah, it's slightly abducted.
Down and out.
Down.
Ptosis down and out. Dilated pupil. 3.
3.
Okay, let's move on. C.
Unable to abduct the right.
Okay. So what do you think?
These 6 okay, abducens or lateral rectus.
Okay. D.
Unable to adduct also.
Okay. So that's still third now.
Third.
Yeah.
What about E?
Unable to elevate the right eye in superior rectus.
Okay. And then F.
Looking down.
Can you look down?
It's incomplete.
So what do you think? Yeah, so it's cavernous sinus syndrome. Okay, so you can see cavernous sinus. We have 3, we have 4, we have 6, V1 and V2, and then there is the internal carotid artery as well. So causes like thrombosis. One of the most common causes is actually infection, and they usually present with fever as well as chemosis and proptosis because of the compression of the veins, which take back blood from the face to the cavernous sinus. So orbital cellulitis is, that's why we need to treat orbital cellulitis very fast and very aggressively to prevent cavernous sinus thrombosis. Other things could be anything, like if there is a tumor around there, if there is an aneurysm of the internal carotid, or if there is a fistula between the cavernous sinus and the internal carotid, that can also cause. So I think this is my last slide. This is just something you know: syndromes, cavernous sinus, CP, angle lesion 578, and then bulbar and pseudobulbar pulses, which you all know. I think we are exactly in time. Now